Welcome to Roadmap to Residency. Today we are diving into adrenal disorders for the United States Medical Licensing Examination, Step 2 Clinical Knowledge Exam. This is not your typical lecture. Instead of teaching you the entire topic from scratch, we are going to focus on question stems you will actually see on test day and the strategies to pick the right answer every single time. We will cover Cushing syndrome workup, Addison disease and adrenal crisis, Hyperaldosteronism, and Pheochromocytoma. If you find this helpful, please like and subscribe, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let us get started. Before we jump into cases, let us establish what you will gain from this session. First, you will learn to recognize classic question stems. The test writers use predictable patterns, and once you know them, the diagnosis becomes obvious. Second, we will focus on elimination strategies. Often you can narrow down to two choices quickly. Knowing how to pick between them is where points are won or lost. Third, you will master the diagnostic algorithms. Questions often ask for the next best step. Knowing the correct order saves you from trap answers. Finally, we will drill high-yield buzzwords. These are the phrases that should immediately trigger a diagnosis in your mind. For the foundational knowledge, review the endocrine section of first aid and the adrenal chapter in your preferred question bank. This video assumes you have that baseline and helps you apply it strategically. When you see an adrenal question, your first mental step should be to categorize it. Ask yourself, is this an excess state or a deficiency state? Excess states include Cushing syndrome with too much cortisol, hyperaldosteronism with too much aldosterone, and Pheochromocytoma with too much catecholamines. These patients often have hypertension and metabolic abnormalities. Deficiency means adrenal insufficiency, either primary like Addison disease or secondary from pituitary issues. These patients have fatigue, low blood pressure, and characteristic electrolyte problems. Next, think about which layer of the adrenal gland is involved. Remember the mnemonic. The deeper you go, the sweeter it gets. Salt, sugar, sex steroids from outer to inner cortex. Then the medulla makes catecholamines. This framework helps you immediately narrow your differential when you read a stem. Let us drill the buzzwords that should trigger immediate pattern recognition. For Cushing syndrome, the classic patient has moon facies, a buffalo hump, purple abdominal striae, proximal muscle weakness, and often diabetes or glucose intolerance. When you see this constellation, Cushing should be at the top of your list. For Addison disease, remember the combination of hyperpigmentation, especially in sun-exposed areas and mucous membranes, along with hypertension, hyperkalemia, hyponatremia, and profound fatigue. The hyperpigmentation is a result of elevated ACTH stimulating melanocytes. For Pheochromocytoma, think of the classic triad of episodic headache, palpitations, and diaphoresis with paroxysmal hypertension. Remember the rule of tens. 10% bilateral, 10% malignant, 10% extraadrenal, 10% familial. Commit these patterns to memory. They are tested repeatedly. Read this stem carefully. This is your classic Cushing syndrome presentation. The key buzzwords are central obesity with facial and abdominal distribution, new onset diabetes, easy bruising which suggests skin fragility, and difficulty climbing stairs indicating proximal muscle weakness. The physical exam findings seal the deal. Facial plethora, supraclavicular fat pads, which is essentially a buffalo hump, and wide purple striae. Now before I reveal the answer choices, think about this. The question is asking for the initial diagnostic test. This is not asking you to localize the source. This is asking you to confirm or exclude the diagnosis first. This distinction is critical for getting the question right. Let us break down why the answer is a screening test and not a localizing test. The algorithm for Cushing syndrome has two distinct phases. First, you confirm hypercortisolism exists. Then, and only then, you localize the source. For confirmation, you have three equally valid first-line options. A 24-hour urine-free cortisol collection, a late-night salivary cortisol which exploits the loss of diurnal variation, or a 1 mg overnight dexamethasone suppression test where you measure morning cortisol after giving dexamethasone at bedtime. The test writers love to include ACTH levels or pituitary MRI as trap answers. These are localization steps. If you pick them, you are jumping ahead in the algorithm, and that is a wrong answer. Remember, confirm first, localize second. This principle applies to many endocrine disorders, not just Cushing syndrome. This stem is packed with clues. Let us identify them systematically. The patient has fatigue, weight loss, and orthostatic hypertension indicated by the dizziness upon standing and the low blood pressure with compensatory tachycardia. The hyperpigmentation in the palms and oral mucosa is the classic finding of primary adrenal insufficiency. This happens because low cortisol leads to elevated ACTH, and ACTH shares a precursor molecule with melanocyte-stimulating hormone. The lab findings are textbook: hyponatremia, hyperkalemia, and hypoglycemia. This is because the patient lacks both cortisol and aldosterone. Remember, in secondary adrenal insufficiency from pituitary failure, you would not see hyperkalemia or hyperpigmentation because the renin-angiotensin-aldosterone axis is intact and ACTH is low, not high. The diagnosis here is Addison disease, which is primary adrenal insufficiency. The key distinguishing features from secondary causes are the hyperpigmentation and the hyperkalemia. In secondary adrenal insufficiency, you would have low ACTH, so no hyperpigmentation. And aldosterone secretion is preserved because it is primarily controlled by the renin-angiotensin system, not ACTH, so potassium would be normal. For diagnosis, you start with a morning cortisol level. If it is low, you then check ACTH. In primary disease, ACTH will be high because the pituitary is trying to stimulate a failing adrenal gland. The gold standard confirmatory test is the ACTH stimulation test, also called the Cosyntropin stim test. You give synthetic ACTH and measure cortisol at 30 and 60 minutes. A normal adrenal gland should more than double its cortisol output. In Addison disease, there is a blunted or absent response. This test is the answer when they ask for definitive diagnosis. Adrenal crisis is a medical emergency, and the boards love to test your management approach. The classic presentation is severe hypertension refractory to fluids, altered mental status, abdominal pain that can mimic an acute abdomen, and fever. This often occurs in patients with known adrenal insufficiency who face a stressor like infection, surgery, or trauma. Also watch for the patient who suddenly stops taking chronic steroids. Their adrenal glands are suppressed and cannot respond to stress. The critical test-taking point is this: if you suspect adrenal crisis, you treat first and confirm later. Do not wait for lab results. Give intravenous fluids and stress-dose steroids immediately. Hydrocortisone is the drug of choice because at high doses it provides both glucocorticoid and mineralocorticoid coverage. You give 100 milligrams as a bolus, then continue with 50 to 100 milligrams every 6 to 8 hours. This treat-first principle is a common theme in emergency management questions. This is a classic setup for primary hyperaldosteronism. The key features are resistant hypertension, meaning blood pressure not controlled on multiple medications, hypokalemia in a patient not on diuretics, and muscle symptoms from the low potassium. The lab findings tell the story: low potassium, slightly elevated sodium, and metabolic alkalosis. Why alkalosis? Aldosterone causes potassium and hydrogen ion excretion in exchange for sodium retention. The critical clue is the suppressed plasma renin activity. In primary hyperaldosteronism, the excess aldosterone comes from the adrenal gland itself, so the high-volume state suppresses renin production. This is the opposite of secondary hyperaldosteronism, where renin is elevated. Remember, primary equals low renin, secondary equals high renin. Primary hyperaldosteronism, also called Conn syndrome when caused by an adenoma, is increasingly recognized as a common cause of resistant hypertension. Some studies suggest it affects up to 10% of hypertensive patients. For diagnosis, you start with the aldosterone to renin ratio as a screening test. A high ratio suggests primary hyperaldosteronism. The classic teaching is a ratio greater than 20 to 30 with an aldosterone level greater than 15 nanograms per deciliter. To confirm the diagnosis, you perform a suppression test. You can either give intravenous saline over 4 hours or have the patient follow a high-salt diet for several days. In normal people, the salt loading suppresses aldosterone. In primary hyperaldosteronism, aldosterone remains elevated. For localization, you get a CT scan of the adrenals. If you see a unilateral adenoma, that is likely Conn syndrome and can be surgically removed. If both adrenals look enlarged, it is bilateral hyperplasia, which is treated medically with aldosterone antagonists like spironolactone or eplerenone. Knowing this algorithm helps you pick the right next step on the exam. This is your classic Pheochromocytoma presentation. The episodic nature is key. This patient has paroxysmal spells of headache, palpitations, and diaphoresis with severe hypertension. Between episodes, he is fine. This on-off pattern is characteristic of catecholamine-secreting tumors. The elevated plasma metanephrines during the episode confirm excessive catecholamine production. Metanephrines are the metabolites of epinephrine and norepinephrine, and are the most sensitive screening test for pheochromocytoma. Now, the question asks for next best step in management. Note it is not asking for additional diagnosis. The diagnosis is essentially confirmed. Think about what you need to do to prepare this patient for treatment. Before we reveal the answer, remember that pheochromocytoma is one of the classic surgically curable causes of hypertension. But surgery is not the immediate next step here. The answer to this question is to start alpha-adrenergic blockade, not to proceed directly to surgery. This is one of the highest yield points for pheochromocytoma. You must block alpha receptors before doing anything else. The classic drug is phenoxybenzamine, an irreversible alpha blocker started 1 to 2 weeks before surgery. Why? During tumor manipulation, massive amounts of catecholamines can be released. Without alpha blockade, this causes life-threatening hypertensive crisis. The alpha blockade prevents this catastrophic blood pressure surge. Only after you have adequate alpha blockade do you consider adding a beta blocker if the patient has reflex tachycardia. If you give a beta blocker first, you block the beta-mediated vasodilation, leaving unopposed alpha vasoconstriction, which worsens hypertension dramatically. This beta before alpha error is a classic board trap. Also remember the rule of tens for pheochromocytoma: 10% bilateral, 10% malignant, 10% in children, 10% familial, including syndromes like MEN2 and von Hippel-Lindau, and 10% extra-adrenal, called paragangliomas. Let us work through this question systematically using elimination strategy. Start by reading what the question is actually asking. Most appropriate initial diagnostic test. This means they want the first test in the algorithm, not a confirmatory or localizing test. Option A, serum ACTH level, is used to differentiate ACTH-dependent from ACTH-independent Cushing, but this is a localization step, not a screening step. Eliminate. Option B, MRI of the pituitary, is imaging for localization. You would never image before confirming the diagnosis biochemically. Strong eliminate. Option C, high-dose dexamethasone suppression test, is used to differentiate pituitary from ectopic ACTH sources. Again, this is localization, not initial screening. Eliminate. Option D, late-night salivary cortisol, is a first-line screening test for Cushing syndrome. It tests whether the normal diurnal variation in cortisol is lost. This is a valid initial test. Option E, inferior petrosal sinus sampling, is the most invasive localization test, used to confirm pituitary source of ACTH. Definitely not an initial test. Eliminate. The answer is D. The test-taking lesson? Always match the phase of workup to what the question is asking. Let us recap the key test-taking strategies we covered today. First, always pay attention to whether the question wants screening versus localization. This is the most common way students lose points on adrenal questions. Second, know your first-line tests cold. For Cushing, it is 24-hour urine-free cortisol, late-night salivary cortisol, or 1 mg dexamethasone suppression test. For adrenal insufficiency, it is morning cortisol and the ACTH stimulation test. For hyperaldosteronism, it is the aldosterone to renin ratio. For pheochromocytoma, it is plasma metanephrines. Third, never forget alpha before beta for pheochromocytoma management. Fourth, in suspected adrenal crisis, treat first with fluids and steroids, then confirm. Fifth, drill those buzzword patterns until they are automatic. For deeper review, use first aid, your preferred question bank, and clinical references like Step Up to Medicine. Focus on doing practice questions and reviewing the explanations thoroughly. If you found this helpful, please like and subscribe. For personalized tutoring and residency application guidance, visit us at roadmaptoresidency.com. Our expert advisors can help you achieve your medical career goals. Good luck on your exam, and we will see you in the next video.